about epidural anesthesia and how to convert a working labor epidural to a anesthetic for lower segment cesarean section. As we all know, it is the commonest major surgical procedure performed worldwide, and it is approximately 1 in 5 births we do cesarean sections worldwide. WHO recommends that a cesarean section should be available for any woman who requires it at any place. So let's go through the history a little bit. Cesarean sections were introduced before 15,000. It was done on dying or dead mothers. The successful cesarean section where the mother survived was done in 15,000. Until 19th century, the maternal mortality was extremely high, the reason being hemorrhage, infection, and no anesthesia. With the introduction of anesthesia, antiseptic techniques, uterine suturing techniques, blood transfusion services developing, and introducing antibiotics, things became better and the mortality rate reduced. Currently, modern surgical and anesthetic techniques have made lower segment cesarean sections a very safe procedure. So let's talk about when and where we introduced anesthesia. The introduction of anesthesia was in 1847 with ether and chloroform, and general anesthetics were performed for lower segment cesarean sections until 1905, where procaine was introduced and epidurals, caudals, and spinals started appearing for anesthetic techniques. General anesthesia was a little unpopular because there was this Mendelssohn syndrome, which is actually the syndrome was related to aspiration, and this person Mendelssohn was the one who highlighted it, and that is why it is called the Mendelssohn syndrome. And this was in detail analyzed in the confidential inquiry into maternal deaths in 1957, and the recommendations were introduced on acid prophylaxis to prevent aspiration syndrome. Torque needle and catheter was introduced in 1940s, in lignocaine in 1950, and bupivacaine in 1970. Spinal anesthetics were done along with general anesthesia, but in 1950s, because of this Woolley Rowe case, where 2 patients were paralyzed after spinal, it became unpopular until 1990s. And there were a lot of cases related to post-dural puncture headache because very thick needles were used for spinal. In 1990, again, spinals came into practice, and with 25 and 27 gauge needles, and until now it is the most popular mode of anesthesia for obstetric patients. Now, as you can see in this graph, in 1970s, general anesthesia was more popular, and you can see the maternal mortality rate was 30 to 50 per 100,000 maternities. But after introduction of spinal anesthesia or regional techniques in early 1980s and 1990s, it became half, 19 per 100,000 maternities. It was becoming popular due to 2 reasons. One is maternal benefits, other one is related to fetal benefit. The maternal benefits are low risk of difficult airway and elimination of accidental awareness in mothers. Fetal, better APGAR score and improved umbilical cord pH. The risk of general anesthesia to the mother as well as the fetus was identified. Maternal risks were difficult and failed intubations, rapid desaturation due to low FRC, and aspiration syndromes, accidental awareness, pulmonary thromboembolic complications after surgery, and severe pain postoperatively. Fetal risks were due to transfer of anesthetic agents, neonatal respiratory depression, lower early APGAR score, and which needed neonatal resuscitation. But can we avoid general anesthesia? No, we can't. The reason being there are certain indications for general anesthesia, and I would like to highlight the indications because we all have to have some practice on general anesthesia because it is a modality which we have to use in certain situations. Insufficient time to establish a subarachnoid block for urgent delivery or difficulty in positioning, such as cord prolapse, where you need to quickly get the patient under anesthesia for the delivery to save the baby. Failed or inadequate regional techniques, we have to go for general anesthesia. Then there are contraindications for subarachnoid block, such as major anatomical abnormalities like spina bifida, symptomatic back pain like disc prolapse with plus spinal surgeries, severe coagulopathy where the platelet count is less than 50,000 and INR is more than 1.5, severe antepartum hemorrhage or where, with cardiovascular instability, or in situations where we can anticipate major hemorrhage such as placenta creta and precreta. Patient refusal and nature of the surgical procedure where the time takes longer in situations where you need relaxation more, we have to go for general anesthesia. So in both general and regional anesthetic techniques, whatever the technique we do, we have to prepare the patient for a general anesthetic because it can always be a failed regional technique where we have to convert it to a general anesthetic. So evaluation of the patient's other systems is very important, and optimizing those systems, pathologies is very important. And also a detailed airway assessment is important as for a general anesthetic. Checking all the investigations and optimizing the systems, looking at the investigations is very important, and also should have a recent full blood count, and blood should be available at least 1 pint for a normal cesarean section without any complication. In other conditions where we anticipate blood loss, we have to have more blood. Antacid prophylaxis is important with H2 receptor blockers, famotidine, cimetidine, ranitidine, prokinetics such as metoclopramide, and non-particulate antacid sodium citrate. Informed written consent should be taken. So if we are going for a general anesthetic, the most important thing that we have to remember is the airway. One thing, it is because of the maternal physiology and anatomy, it can give rise to a complicated, difficult airway. So there are 3 things that we have to prepare. 1, equipment. 2nd, get the monitors on. 3rd, we have to have the adequate manpower. So what are the equipment that we should have? 2 laryngoscopes, preferably the McCoy blade and with the polio handle, and another, the conventional laryngoscopes. Size 6.5, 780 tubes, size 3 LMA, bougie, stillet, suction, tiltable theater table, stethoscope, and tapes. Monitoring Standard monitoring, saturation, NIBP, CAPNO, ECG, and a running drip with a 16 gauge or 17 gauge cannula. Manpower, obstetric team should be prepared to do the section scrubbed to start off when the anesthetic is given. Trained help to apply cricoid pressure, senior cover-up, availability of an anesthetist who could attend to an emergency if necessary. Apart from that, emergency drugs like atropine, ephedrine should be available on the table, and anesthetic machine should be checked and ready. Positioning of the patient is very important. Left lateral tilt with 15 to 30 degrees, which will displace the uterus, and it will reduce the compression of the IVC, will help fetal blood flow and reduce not reduce the umbilical cord pH. 20 to 30 degree head-up tilt will lower the gastric pressure, reduce passive regurgitation, and it can also increase the FRC, increase safe apnea period. Now let's look at these two diagrams. If the patient is lying flat, you can see that the diaphragm has splintered up, the airway alignment is not good, and also definitely it would increase the lower esophageal, because of the lower esophageal sphincter tone is decreased and intragastric pressure is increased, regurgitation is possible. So if the patient is propped up on rapid airway management position, which is 20 to 30 degrees head-up tilt, diaphragm is pushed down, FRC improves, safe apnea time prolongs, reduce gastroesophageal reflux because of the gastric pressure going down, and also the airway alignment is much better to handle the airway, and also the breasts are displaced and the maneuver will be much easier. Okay. The lateral tilt, you can see here, if it is totally supine, the patient is having complete block or occlusion of the IVC. If it is 15 degree left tilt, it might slightly reduce the block or the compression, but if it is 30 degrees, that will definitely open up the IVC, which will improve the blood flow, and that can actually improve the fetal circulation and not hinder the umbilical cord pH drop. So after preparing the monitoring and drugs and positioning the patient, we have to pre-oxygenate the patient. There are two things that are very important here. Earlier, we used to do pre-oxygenation for 5 minutes, but right now it is recommended that 100% oxygen with a close fitting mask to be applied until the FETCO2 reaches 0.9. Now we have actually gas analysis and measurement in most of the monitors, so we can look at that and then we can reach that number or at least near that number, so that we have a good oxygen reserve in the patient. Also, we can go for a face mask which fits tightly with a maximum PIP of 20 centimeters water, which can improve the oxygen stores in the patient. Then there's another way we can actually increase the safe apnea period by THRIVE, that is transnasal humidified rapid insufflation ventilatory exchange, where we can put a nasal prong or a nasal cannula and give oxygen 5 liters during intubation, which is called apneic oxygenation, or else we can go for a high flow nasal oxygen device giving oxygen 30 to 60 liters per minute during intubation. This will actually help the patient not to drop the blood pressure, not to drop the oxygenation, and also for the anesthetist to be calm and less stressed out when the patient is being intubated. After pre-oxygenation, what should we do? We should induce this patient. Now, the traditional rapid sequence induction was actually introduced in 1970, where we pre-oxygenate for 5 minutes, and then we give thiopentone and suxamethonium with cricoid pressure, which is called the Selick maneuver, and then avoiding bag mask ventilation, we intubate, secure the airway with the cuff, and remove the cricoid pressure. But right now, it's a bit different. I would talk about the modified rapid sequence induction later, but before that, let me tell you about the Selix maneuver. Selix maneuver is done to reduce regurgitation and aspiration, and we use the cricoid cartilage, which is the round complete cartilage below the thyroid, to press onto the vertebrae so that the esophagus is occluded and there is no stuff coming out of the stomach to aspirate. So earlier it was such that we applied 40 newtons, but now it's said to apply 10 newtons in an awake patient, and when the patient is unconscious, to go for 30 newtons. So with the introduction of propofol, which is quite popular right now, we have replaced thiopentone. We have replaced thiopentone to propofol, and in situations where the patient's pressures are not great, we can use ketamine, and if the patient is a cardiac patient with issues related to hypotension, we can go for etomidate. So if the anesthetic agent is replaced, then we call it modified rapid sequence induction. Suxamethonium is the agent of choice for muscle paralysis, but if it is replaced by rocuronium, again, it becomes modified rapid sequence induction. Rocuronium is used with sugammadetes. In case we can't intubate, we have to reverse the effect of the drug. So these are the modifications right now from the conventional intubation technique, induction technique, which we had some time back. Pre-oxygenation is now 2 minutes only to achieve FeTO2 of 0.9. Then we can go for apneic oxygenation with a nasal cannula with 5 liters per minute throughout while the patient is intubated. The induction drugs, propofol is in favor over thiopentone, and cricoid pressure is applied at 10 Newton when the patient is awake, and it is increased to 30 Newton when the patient goes unconscious. You can reduce it to 20 Newtons if the head is up. They say that you can gently bag mask ventilate if the patient desaturates during the apneic period, but I don't know whether it is usually done in our setup. We always try to intubate before the patient desaturates, but there can be a situation where the patient cannot be intubated on the first course, and if the patient is becoming hypoxic, you can always think about gentle ventilation, bag mask ventilation with cricoid pressure on. Then for intubation, it is recommended to use video laryngoscope as the first line and to put a size 7 endotracheal tube. Why is it recommended to intubate with a video laryngoscope? The Difficult Airway Society and Obstetric Anesthetic Association has now recommended it as the first line because we do not have to have a perfect line alignment of the axis of the airway with the video laryngoscope. Therefore, we do not have to use much force or manipulations when we are intubating a maternal patient, and it can prevent any breast obstruction related to engorged breasts. So that is why they have recommended it. And also when you're using force to mitigate breast obstruction, you can injure the oral cavity because the oral cavity is usually very fragile edematous. So that also can be prevented with video laryngoscope. But in our setup, we don't have video laryngoscopes everywhere. So we may have to go for the conventional laryngoscope. But McCoy blade laryngoscopes with polio handle is very useful for us to avoid the engorged breasts hindering the manipulation, and also to prevent extensive neck extension while intubating the patient. We can pick up the epiglottis with the McCoy blade lever. After intubation, securing the airway, we can continue anesthesia with an adequate depth, oxygen, nitrous oxide or medical air with inhalational anesthetic agent. It is recommended to keep the MAC at 10, MAC at 1, but if you increase the MAC more than 1, then there will be neonatal respiratory and depression and due to transplacental drug transfer, and also there will be uterine atony. So MAC at 1 would be the best, but if it is less than 1, it can give rise to accidental awareness. So we have to think about preventing that also. So keeping the MAC at 1 is the best for these patients. NICE and RCOG recommendations suggest antibiotic administration prior to skin incision because it will avoid overall infectious morbidity. Analgesia. It should be multimodal, but we can't give morphine, fentanyl, pethidine, opioids before the baby is delivered. So it's always advisable for us to give diclofenac sodium, PR, or paracetamol, PR or IV, when the patient is on the table, so that it will work before the delivery, and after delivery we can administer the opioids. Local anesthetic infiltration on the wound would keep the patient comfortable in the post-op period, and tap blocks are also suggested, which is a very good method to prevent post-op pain, and it will last for about 24 hours, bupivacaine 2 mg per kg. Oral and IV paracetamol and NSAIDs should be prescribed on regular basis for all patients. Actually, this is not happening in most of the wards, and I feel that it has to be accentuated to give regular, simple analgesics, at least to prevent discomfort in these patients. Aspiration risk is present at extubation because they are having a full stomach. So awake extubation with lateral or propped up position would be the best. Okay, so I have taken you through the general anesthesia for obstetrics, obstetric patients. Let's go through the commonest anesthetic technique that we use to anesthetize obstetric patients: subarachnoid block. Now, I would like to emphasize on the skin preparation. Internationally, chlorhexidine is recommended to clean the skin as the cleaning agent, but in Sri Lanka, we don't have chlorhexidine. So therefore, we go for betadine, povidone iodine for skin antisepsis. Leaving betadine in touch with the skin for a minute, at least minimum a minute, should be the recommendation, is the recommendation, and it should be taken out with alcohol or saline. Reason why it should be taken out is because if it is introduced to the meninges, you can get chemical meningitis, and that can give rise to neurotoxicity. The National Audit Project 3, which emphasized on the neuraxial blocks, gave recommendations on asepsis for all the neuraxial blocks, that is subarachnoid, epidural, caudal, and so on and so forth. So the optimal technique of full asepsis is required. Sterile gown use should be encouraged, especially with trainees. Sterile gowns should be available for any clinician who feels that it will benefit maintaining a sterile procedure. So I do not think that we should go, have shortcuts for this, because it is actually a very important and a serious aspect when it comes to sepsis. So identification of the space, how do we do it? We actually palpate the posterior superior iliac spine, and we draw the tertius line, and that is how we get the landmark at L4, and we palpate and get the spaces L3, L4, or L4, L5 for our spinal anesthetic, where it will avoid trauma to the cornus. But right now, they say that it is a very inaccurate way of finding the space. And now that ultrasound is introduced everywhere, it is recommended to do a pre-procedural ultrasound, which means an ultrasound assisted identification of the vertebral level. You mark the level and then you go for the spinal anesthetic. But in our setup, we do not have ultrasounds everywhere, so I think we may have to go for the Tafier's line and do our spinals with L3, L4, and L4, L5 space. So in difficult subarachnoid blocks or very obese patients where you are anticipating a difficult subarachnoid block, actually you can use the ultrasound to find the spaces. Okay, so let's go through the drugs that we can use for subarachnoid block. Hyperbaric bupivacaine, 9 to 12 milligrams, and we use 0.5% solution, 1.8 to 2.4 ml. In other countries, they have 0.75% solution, so the dose becomes less, 1.2 to 1.6. I think I have never used 1.75, so I have no experience to talk about it. Isobaric bupivacaine we use for subarachnoid blocks. There was a time we had to use because we didn't have hyperbaric bupivacaine, 9 to 15 milligram. And there we had to cut down on the dose because it can, spread up even with a small dose. So the adjuvants that we use as opioids are fentanyl, 10 to 25 micrograms, serfentanyl, 2.5 to 5 micrograms, diamorphine, 300 micrograms, and morphine, 100 to 200 micrograms. With this, with adding opioids, we can increase the time duration for pain relief And fentanyl 3 to 4 hours, fentanyl 5 to 6 hours, diamorphine and morphine 24 hours. There are other H1s also, alpha-2 receptor blockers, clonidine, dexmedetomidine, and adrenaline, neostigmine, magnesium, ketamine, and midazolam. I'm not very familiar with adrenaline, neostigmine, magnesium, ketamine, and midazolam. Probably in other countries they may be using it. So with the volume that we are going to use for a spinal injection depends on the height and also on the patient as well. Now, we have to remember the gravid uterus is having some adding pressure to the spinal canal also. So the spine subarachnoid space is also shrinked. So we should think about giving a smaller dose compared to an otherwise normal patient. So height, this is a rough guide that I have got here. Less than 140 centimeters, we have to stick to less than 2 ml. 140 to 150 centimeters, 2 to 2.25 ml. 150 to 160 centimeters, 2.25 to 2.5 ml. And over 160 centimeters, you can go up to 2.75 ml. There are other contributory factors on the that can affect the level. Speed of injection. If we go slow, the speed when we are injecting, the rise will be slow as well as the level also can be slow, can be low. Then positioning the patient. And also the patient factors such as having any abnormalities in the spinal cord or the vertebral shape like kyphoscoliosis and scoliosis. So testing the level of the block is very important. Adequacy of the block should be assessed ideally before we start with two sensory modalities. There's no clear gold standard. Sensation should be checked in the mid-clavicular line. The recommended level of the block that should be there for a cesarean section is T4, T5. Reason being the peritoneum is innervated from T6 to T4. So we have to cover that. And that is why sometimes the patients feel when they suture the peritoneum. Supplementary analgesics may be required even if the block is adequate. So we may have to give a bit of fentanyl or midazolam if the patient shows discomfort. If the patient is showing discomfort, we have to respond immediately and liaise the anxiety and the discomfort, and sometimes we may have to convert it to a general anesthetic without much waiting. Okay, so when we give a single shot spinal, sometimes we end up with a situation where the block is inadequate prior to skin incision. If that is so, if the block is not working at all, or this patient is not at all anesthetized and this with the block, we have to replace the neuraxial. We have to go for a replacement of a neuraxial technique or convert it to a general anesthetic. Ideally speaking, a general anesthetic would be the best. If you're going to replace it to a neuraxial technique, I would say that it has to be informed to a consultant, and a consultant's advice should be taken prior to going for another neuraxial technique. Reason being, if you go for a neuraxial technique and both blocks work, it can go into a high or a total spinal. So if you're going to go for a neuraxial technique, CSC would be the safest, where you go for a very low dose of spinal and top up the epidural to get the desired block, and that would be the best way to go for a neuraxial. But if time does not permit, I think general anesthesia, converting the anesthetic to a general anesthetic would be the best. Okay, so now sometimes we have this problem. Okay, the patient skin incision is all right, patient tolerates, but the patient starts responding before the peritoneum is open. Then you may have to convert it to a general anesthetic. Then again, you have got a patient who is responding, or when the pain, with pain after the peritoneum is open. Then again, you have to convert it to a general anesthetic if the patient is very in a lot of distress. But if the patient is not in such a distress, you can try adjuvants such as nitrous oxide oxygen, alfentanil, fentanyl, midazolam. These are the drugs that we can use to as adjuvants with the subarachnoid block. Never administer propofol or thiopentone without securing the airway. So we all have encountered this problem. With a spinal anesthetic, there is a pressure drop. We can accommodate a pressure drop up to 90% of the baseline, but otherwise we have to go for alpha agonist drugs to increase the blood pressure. The best drugs that are recommended are phenylephrine and metaraminol that will not cause fetal acidosis. But ephedrine does cause fetal acidosis, so it is not the best to give. In our setup, we give it because it is cheap and it is freely available. Phenylephrine and metaraminol are quite expensive, so we use it very sparingly. It is recommended to start phenylephrine prophylactically as an infusion immediately after the subarachnoid block, and that cannot be done in our setup because we don't get phenylephrine that much to give to all the patients. So if we are to give boluses, how do we do that? If the blood pressure is low and the heart rate is normal, we can go for phenylephrine or metaraminol. But if the blood pressure is low and heart rate is also low, ephedrine bolus would be better. So if a patient ends up with a high spinal block, how are we going to handle it? Now, if it is intracranial spread, where the cranial nerves are involved, patient becomes drowsy, complete loss of consciousness, and cardiorespiratory arrest. That says that we have to go for the ALS protocol, immediate ABC. If the patient is having a block from C3 up to C3, the C3, C5 innervation is for the diaphragm, and the patient is going to be having difficulty in breathing because the diaphragm is paralyzed and the thoracic muscles are paralyzed, slurred speech, and shoulder weakness. You have to reassure the patient, get the patient on 100% oxygen, and assess the airway and immediately intubate the patient, secure the airway. If the patient's arms and hands are tingling and progressively weakening the grip, that says that the patient is having a high spinal, but you can reassure the patient. If it is an epidural infusion, you can stop. Otherwise, if it is a subarachnoid block, you may have to position the patient such that the block doesn't ascend more, and you can give oxygen and deal with the cardiovascular stability. If T1, T2, T3, T4 levels are caught, that is cardiac sympathetic fibers, we can see a severe bradycardia and a blood pressure drop. So the left lateral tilt is important. Ephedrine, metronidazole, atropine should be administered to stabilize the patient. So if you have such a situation, immediately call for help. Obstetric, anesthetic, and neonatal teams, if the patient is not delivered yet, then go for hemodynamic stability, give the drugs, and continuously monitor the patient, get the blood pressures up and the heart rate up. Positioning the patient is very important with anti-Trendelenburg position, and continuous monitoring while you're treating the patient. If there is an airway problem, airway alert, quickly go for intubation and quick go for securing the airway. For that, you may need modified rapid sequence protocol. You can use midazolam and succinylmethonium with modified rapid sequence induction and secure the airway with the ET tube. And when the block wears off, you can recover the patient. So there's a thing called rapid sequence spinal, which is done for category 1 cesarean sections where there is a life-threatening condition for the mother. So rapid sequence spinals are not really done in our setup, but sometimes we may have to do it. So I would like to tell you a little bit about it. If a patient is having contraindications to general anesthesia, and if you have to go for a rapid spinal, then how are you going to do it? You delegate the activities to various people. IV cannulation, one person, get the airway equipment ready for another person, anesthetic machine, drugs, and positioning the patient. And you can give the spinal with mask, hat, and gloves on without a sterile gown, but it's no touch technique for a spinal needle insertion. Before inserting the spinal needle, you can have a single wipe of chlorhexidine solution and remove it with a dry swab and go for the spinal injection. It's only one attempt, and you should give a higher dose of hyperbaric bupivacaine, and you get the patient down and commence the surgery when the block is at T10 level, and the block will creep up while they are doing the section. But you have to be prepared to administer immediate GA if the spinal is inadequate. They say that the spinal anesthetic should take only 5 minutes, and by 7 minutes, the skin incision should go in. So that is a rapid sequence spinal, which we can do in extreme conditions where a general anesthetic may not be feasible. So let's talk a little bit about controlled epidural anesthesia. It's very important for us to know this, because most of the patients who are having cardiac issues, we go for controlled epidural anesthesia, and the skin preparation is for spinal anesthetic. We use a torque needle 18 gauge a catheter 20 gauge. Loss of resistance we do with saline and AR, but right now we do it with only saline because AR is not sterile. So saline is the recommended way of getting the loss of resistance. And a test dose of bupivacaine 15 milligrams, that is 0.5%, 3 ml will be given. And then the top ups are given to achieve the desired level. Now, recently I read an update, and there is a new syringe. This is called a smart syringe to identify the epidural space. So when you push this syringe continuously in, immediately when it reaches the epidural space, the plunger goes in and there is a yellow color appearing in the piston, which says that the patient, we have entered the epidural space. Earlier, the practitioner is the one who feels the epidural space entry with loss of resistance, but this smart syringe is doing that for us right now. So I don't know at what point we are going to get that kind of a smart syringe, but that is the way forward in epidural anesthesia. When we have an emergency section with a working labor epidural, how are we going to change it to an anesthetic epidural? Well, first you have to find out whether the epidural is in situ in right place, and then in our setup we actually give bupivacaine top-ups and get the patient's level up. But it is recommended to give 2% lignocaine, 2 to 3 ml top-ups. And if you want to enhance the action, they recommend to give 1 in 2000 adrenaline with lignocaine and 75 to 100 micrograms fentanyl. If you want to really make it faster, the onset, 8.4% preservative-free sodium bicarbonate can also be added. The top-ups can be initiated in the delivery suite, and the anesthetist can directly monitor the patient while the patient is transferred to the operating suite. This, I think, we do not use lidocaine in our setup. We go for bupivacaine with fentanyl to top up our labor epidurals. So let's compare what we have talked about, the advantages and disadvantages of each type of anesthetic. So subarachnoid block and combined subarachnoid epidural blocks, they have an advantage of rapid onset, and we get a very dense block, but with no sacral sparing, and but the spinal, of course, we can't extend the block. That is a problem. Combined spinal epidural, we can extend the block to whatever the time it needs, and post-op pain relief will be prolonged. Epidural extendable block, slow onset and titrable, so more cardiovascularly stable when we are doing the block. And all three spinal CSCs and epidurals have an advantage where we have an awake patient who can participate in the experience the childbirth with the presence of the partner, and also can have skin-to-skin contact and breastfeeding, and that will improve the maternal bonding. And also it can give effective post-op analgesia. The disadvantages of spinal is immediately after the block, there is a cardiovascular instability which we have to deal with, pruritus and PDPH. CSC is also cardiovascular instability with pruritus and PDPH. Epidural's problem is very slow onset, block less dense, possible sacral sparing, and it can also have pruritus. The general anesthetic is giving us the provision to give a rapid anesthetic with no time for emergency surgery, and it eliminates all the neurological neuraxial complications, no pruritus or PDPH, but the patients are unable to participate in childbirth. We have greater maternal morbidity related to airway problems and accidental awareness, greater neonatal morbidity due to low APGAR score and umbilical venous pH going down, increased requirement for post-op analgesia with opioids and other drugs. So that is why actually the spinals are more in favor in obstetric anesthesia in our practice. These are the references that I went through, and I feel that if your this would help you to improve your practice in obstetric anesthesia with the information that I have given in this presentation. Thank you very much for listening.
Thank you, Siddharshi, for your very comprehensive and informative presentation. There were several questions in the chat box. Already there were the answers in the chat as well. But somebody's asking, isn't it said apparent cricoid pressure is obsolete now?
Sorry, cricoid pressure?
Applying cricoid pressure is obsolete now. Is it like that?
Okay, so applying cricoid pressure is obsolete because we are talking about a patient who is having a full stomach. But the thing is, you can reduce the pressure to 20 newtons if the patient is propped up. But if the patient is not propped up, it should be 30 newtons when the patient is unconscious. It will prevent aspiration, because if by any chance the patient is aspirated with the stomach content, it is going to be a chemical pneumonitis, and that will actually increase the morbidity of the mother.
Okay. So there's another one, Siddharshi. So the patients with betadine allergy, anything else there for that skin preparation?
Yeah, I think we have a problem because we have only betadine. I think in that situation, if we don't have chlorhexidine, we may have to go for spirit only.
And is it better to avoid GA because of the risk of PPH?
Is it better to avoid GA due to the risk of PPH?
PPH, yes, it is.
Yeah. Now, actually, it's not the idea behind going for general regional techniques is to prevent any airway handling, because we all know that the patient is having a short neck, edematous airway, and the intubation may be difficult. And also on top of it, the patient is having a situation where the patient is, we need to have rapid sequence induction with a full stomach. So there is a risk of aspiration. We can avoid all that. And while we are giving very small doses or titrated doses of anesthetic, the patient can end up with accidental awareness. Now, there are so many problems related to general anesthesia. So why go for all that when we have another modality of anesthesia, which is very safe, where we can avoid airway handling, we can avoid aspiration, we can avoid accidental awareness, and on top of it, the fetus is also going to benefit because there won't be any drugs going through the fetal circulation. The baby is going to be born fresh without any respiratory depression. So that is the reason why we have gone for regional techniques. But in case where we can't handle the anesthetic with a regional technique, we have to go for general anesthesia.